So welcome to our third part of session one, in which we're now going to go over some social determinants of health, because now you have an understanding of population health at that level and can incorporate an understanding of actually some social determinants of health. So I'm going to go over some determinants that we think are very important and give you some examples of outcomes. So let's first start with socioeconomic position. This is probably the thing that most captures social determinants of health. It's where most of the research is centered. And the idea is that measures of socioeconomic position indicate structural locations within a society. That is, they place us on a hierarchy in a society. And the determinants of exposures to health-damaging conditions or health-enhancing resources are shaped by socioeconomic positions. So socioeconomic position influences health by a number of health-damaging exposures. That is, they could be environmental, they could be social, they could be stress-related, they could be nutrition-related, they could be related to any number of risks, as well as, at the high end, enhancing resources. And they're often measured by income, occupation, education, and the type and structure of work. So sometimes people combine these indices all together and come up with a summary kind of index. However, I think increasingly people think that there's a rationale to look at each of these things individually and to understand that sometimes education may be the most important of these conditions, the one that is the primal driver of everything else. In other cases, it may actually be income or the type of work that we do or occupation. And so it's interesting to think about these and be critical of them in a positive sense individually. So you will hear more about that in the coming lectures. The second major domain that I think is really important, and in fact where much of my work has been centered, has to do with social networks and social support. And here the idea is that networks are characteristics of ties and patterns of ties between actors in a social system that explains behaviors and other outcomes. So when we look at characteristics of networks, we actually look at the structure of social relationships. Do you know a lot of people? Do they all know each other? Do you have dense networks? Are they very expanded? So we will look at that in another lecture. And again, social support then becomes a function of social ties. And social support can be emotional or instrumental. It can help you appraise a situation. It can be financial. There are a lot of ways social support works. But we don't want to conflate or mix social support and networks. They're two very different things. And one of the issues about networks is, one of the important functions is, do they provide social support? We now come to another really important social determinant, which has to do with social inequality. So social inequality, when we think about the Rose, the population health paradigm, is related to the distribution of income or other factors that influence population patterns of health. And the idea is that on a societal level, does inequality harm us? So while socioeconomic position says, if I'm in a lower socioeconomic position, is it bad for my health? Social inequality says, if I live in a society that's wildly unequal, do I experience worse health, even if I'm not at the bottom? So if I'm a middle income person, am I worse off for living in a society in which there's a lot of inequality? And there is actually a lot of data on this, and we will come back and talk about this. And the question is, if this is true, why is it true? What contributes to this inequality sort of effect, where even though I'm okay in terms of my income or education, I actually experience worse health by living in a society in which people are very unequal? And there are a lot of questions about what is the best area level to assess inequality at. So we sometimes think about inequality as existing at a country level, I do live in a country in which there is a huge inequality. The span between rich and poor is enormous. Is that the right way to be looking at it? Or should I be looking at my neighborhood? Maybe it doesn't matter that I live in a country that's really unequal. Maybe it really matters that I live in a neighborhood in which there's a huge range of inequality. These things are not answered, and they're certainly not answered in many, many countries. The next factor that I think is very important in looking at social determinants is discrimination. So many people experience discrimination. It can be based on racial patterns, as often is in the United States, ethnic patterns, gender, sexual orientation, are often some of the most common groups that we think experience discrimination, but it may be different in different settings. But the idea is that even net of socioeconomic position, if you live in a place where you're discriminated against, you may experience poor health outcomes. And this process by which a member of a socially defined group is treated differently or unfairly is one that's really important to understand. And the idea also is that this can be interpersonal or institutional, direct or indirect. So there are some times when you know you're discriminated against, and there are other times when you may not know at all. So in the United States, we often provide examples of access to housing. So somebody goes in to rent an apartment, the apartment is taken, people don't know, were they discriminated against, or was the apartment just taken? So it can be at a level in which you know it or you don't know it. So this is a very new area, and the measures of discrimination are just becoming well defined, but we suspect it's a very, very important one. And finally, there are a set of work characteristics that have become very important to understand. People can be in very high demand, low control jobs. They can experience a great deal of job insecurity and job loss. Issues of retirement have become important. And the ways in which work itself, shapes health is becoming a very new and important area for social determinants of health. And last is the importance of place, and you will hear more about this as well. So there are often geographic variations in health, from neighborhoods to communities, states, countries, regions. Place almost always matters, and we rarely know why. And rarely is there actually going to be one single answer. They could be physical and environmental factors, they could be social, economic, cultural, policy variations may help to explain geographic variations. So these are the kinds of social determinants that we think are very important in shaping patterns of population health, and for which there are measures developed, but very, very few studies in many countries, and very sparse data on what's the best way to measure these kinds of experiences. So let me give you a few examples, and also to make the point that many of these things we now understand are embedded in a developmental or life course perspective. So we think that early exposures might be very critical. Cumulative exposures, that is, you can experience something in early childhood, but if you keep experiencing it again and again and again and again, this slow drip can actually create cumulative exposures that are very important for health. Or finally, that there are social trajectories. So you have very limited education, and it becomes really important when you find your first job. So your first job includes exposures to lots of chemicals and very risky work situations. So your social trajectory actually matters a lot, not so much an early exposure. So all of these life course issues matter, and you will hear more about that in many of these lectures. So just to give you two quick examples, I'm going to talk about some data, show you some data on the effect of socioeconomic position and inequality over time and different health outcomes, and the importance of social integration networks and support, just to give you a little taste of what's coming down the pike for you. So social disparities within countries. Here is just a very, very simple slide of all-cause mortality among American men by area of socioeconomic status between 1969 and 1998. And what it shows is that over time, these are mortality rates have come down for all economic groups, right? The trends are slopes are going down for everybody. But actually what you see here is that the differences are widening. So that by 1997, if you look at the far end of the graph, the difference between the top and the bottom, the high SES group and the low SES group, has actually gotten larger. So while it's fallen for everybody, mortality rates have fallen more for the best off people. And by falling more for the best off people, it's created a widening disparity over time. The second example I'm going to give is one that should just keep you on your toes all the time. So this is, again, cancer mortality among American men over time. And what you see in the beginning, that is on the far side of the curve in 1950, is that if you looked at cancer mortality, it was the high SES men who had the highest mortality rates. It isn't always true. Now, if you were here, I would ask you all why, and you would give a guess. But since you're not all here, the thing that accounts for this pattern is tobacco consumption. So in the 1950s and 60s and 70s, it was the best off, the highest SES men who were smoking, and they had therefore higher cancer mortality rates. But the intriguing thing is that over time, this is a pattern we often see, the best off people understand that it's risky. They stop smoking, and they experience this enormous drop in mortality, so that after about 1978, 1980, you see the high SES men actually have the lowest risk, and lo and behold, the most disadvantaged groups are now smoking more, and they have increased rates. So we often see, in terms of behaviors, that sometimes advantaged groups take on a behavior, and as they understand that it's risky, they are able, through a set of resources and structural opportunities, to stop and change, whereas more disadvantaged groups take up the behavior and actually show increased rates. So here is just a beautiful example of where you see everything flipping over time. And again, this is an American example. We have no idea what these patterns will look like in many, many other countries over time. So again, both of these happen simultaneously. This just goes back to the first slide, which shows that while there are these changing patterns for cancer mortality, during this same period, you saw sustained patterns for socioeconomic status, always with the best off people having the lowest mortality. The second point I want to make is that inequalities in health are widening in many parts of the world. These are data that are very straightforward. They're showing the relative risk of death, comparing manual to non-manual classes over 3 periods between 1980 and like 1990 in a number of countries. And the lighter colored bars are the later period. And what you see is that over this time, if you compare non-manual to manual or manual to non-manual people, you see the relative risk increasing in all these countries: Finland, Sweden, Norway, Denmark, England and Wales, and in different areas in Italy. And we've seen this in the United States. We've seen it in many other countries. Do we know how it is for 100 countries? No idea what this looks like. But it shows that inequalities can get worse over time. So let me close with an example of social networks. This is really to whet your appetite. So there's a great deal of evidence that social isolation is linked to higher mortality, morbidity, and lower survival. And there's also a lot of data that suggests that caregiving relationships are very, very important for early childhood development. So I want to show you one of the very first studies, actually one that we did, looking at mortality rates by social networks. And in this study, what we did is looked at whether people were married or had a partner, how many friends and relatives they had, whether they volunteered, or whether they belonged to religious communities, and we kind of stacked them up into an index and looked at this social network index. So the blue bars represent the people who have the largest number of ties, who are the most integrated, the least isolated, and you see their mortality rates are quite low. And you see with each step in isolation, there is an increased mortality risk, both for men and women, leading to a very high risk, about 3 times as high among people who are most isolated in the yellow bars. And we have actually done this for many, many countries. So these are results from a World Gallup poll in which that there are 140 countries that participated, and it's looking at the association between self-rated health and social support in a number of countries. So first we look at them in high-income OECD countries, looking at the odds ratios, and you see, with the exception of Switzerland, everything is over 1 in this increasing relative risk. You see the same kind of pattern, although not quite as high, but the relative risks go from 1 to about 2, 2.5 in countries in sub-Saharan Africa. You see the same patterns in South Asia and Oceania, looking at Bangladesh, Pakistan, Nepal, Sri Lanka, India, Australia, Afghanistan, and New Zealand, that the rates go from about 1.5 to 2. And here you see again in East Asia and the Pacific, with the relative risks again going from about 1.5 to almost 3 in places like Taiwan, Hong Kong, and Singapore. But you see very consistent patterns of the association between social support and self-rated health, even though it undoubtedly means very different things in many of these countries. So let me just wrap up this session and again welcome you to the overall course. So where do we conclude this session? First of all, I think the most important thing to think about is that health is socially patterned. It is not randomly distributed in the population. It's very socially patterned. And that while social disparities in health are ubiquitous, that is, they exist everywhere, they're enormously variable. So in some countries, they're very small, and in some countries, they're very large. So this, to me, means, the variability means that this is not nature, this is created, that there is something that we can do about this. While there may always be some disparities, the difference, the size of these disparities is up to us to decide what we can do about. And our challenge is to find the social and economic policies that influence the magnitude of these risks so that we can improve population health and reduce social disparities. So again, I welcome you to the course. Look forward to hearing from many of you, I guess through many venues, and love to hear what you hear about it. Welcome.